Good afternoon.
Hello.
Good afternoon.
Good afternoon.
Hi, Dr. Harry. How are you? You're good?
Hi.
You're well set? Yeah.
I think I'll have to do it on the phone.
Okay.
But I think I should be set.
Okay. Let me share your screen then so that it can be easier for you.
Can you see my screen?
No.
Oh boy. You know, I hope on the phone it's going to be all right. Oh boy.
It should be fine, Dr. Harry. I can screen share on your behalf.
Okay, you have the slides. Yeah, I sent you the slide set.
Yes, I do have the slides.
Yeah, I don't know. I can see my slides on my screen.
Yes.
On my phone screen. Unfortunately, on my laptop, this doesn't seem to be working.
To be working, yeah.
I think I needed an update.
Just give me a second. I will screen share on my side. Okay.
And then if you would be so kind as to just be advancing the slides.
This meeting is being recorded.
Okay. Okay. Think you can see the screen now?
Yes, yes. So if I can touch you, if I can ask you to be just advancing the slides as I go along.
Yes, that's the plan. So
okay, great. Thank you.
So good afternoon, everybody. Sorry for that. Today is Tuesday. We are having a session with Dr. Hafiz Maje and Dr. Emmanuel from the Ministry of Health, who's the Acting Director for Health in Epidemiology. We're going to discuss about cholera. As we all know, cholera started in October last year, 2022, and we've been having an up and down upsurge. Dr. Hafiz would give us an overview of what cholera is about and many more explanations. He's an ID infectious disease trained specialist from University of Alabama. And he's here with us today to give us some insights on how to go about cholera and how we can prevent, how we can treat, and from all dynamics. Welcome, Dr. Hafiz.
Oh, thank you, Dr. Guleid. Can you all hear me?
Yes, we can.
Hello, can you hear? Okay.
Yes,
okay.
definitely, we
audible?
can hear you.
Yeah, right. Okay, thanks, Dr. Guleid, for that introduction. I just wanted to correct one thing. I trained at the University of Alabama. I'm no longer there. In fact, I'm in Mombasa, splitting my time between private practice and also at the Coast General and Teaching and Referral Hospital as well. Yeah, the UAB is a nice place. The University of Alabama at Birmingham is a nice place to train for infectious disease. So just wanted to correct the conception that I'm coming from there. So thank you for asking me to come and talk about cholera. And I'm also glad that Dr. Okunga is here to share the epidemiological wisdom from the public health perspective, from the Ministry of Health perspective. We have this slide where I have the outline of what I'm going to talk about. Are we on slide number 2?
Yes, Dr. Harry, unless you're not able to see it.
Yeah, I cannot see the slides as they are being advanced. I'm sorry about that. Yeah, but okay, so we are on slide number 2. So What I was going to start with was I was going to talk about cholera in the context of infectious gastroenteritis. And then I wanted to touch a little bit about the etymology and the history of the disease. And then I'll seg my way into microbiology, a little bit of epidemiology, some pathogenesis. We'll talk about clinical features, how to diagnose cholera, management, and how one becomes immune to cholera, and what are the methods we can use to prevent cholera. So if we can go on to the next slide, this is an overview slide that shows the decision making when we are faced with a patient with acute diarrhea. Wonderful. Now I can see that you are flashing slide number 3 on the screen. So when a clinician is faced with a patient coming in with diarrhea, the question is it an acute diarrhea or is it a chronic diarrhea? The dividing line being 14 days. If it's an acute diarrhea, is it an acute watery diarrhea or is it an acute bloody diarrhea? So that's the infectious gastroenteritis landscape. Is it an acute or is it chronic? If it's acute, is it watery or is it bloody? The next slide shows us the common pathogens that are seen in acute watery diarrhea in children. And the slide that will come after this will show us the common pathogens in acute watery diarrhea in children. And so the stage is being set for our talk that cholera falls within the acute watery diarrheas. It's not a bloody diarrhea. It's an acute watery diarrhea, and so the pathogens that cause acute watery diarrhea are the ones we will be thinking about on this slide and the next slide. If we can go on to the next slide, which shows us the common pathogens in acute watery diarrhea in adults. Now, cholera does not always have to come in the form of an epidemic or an outbreak. Cholera can occur sporadically. It doesn't have to be only in developing countries. You can have sporadic cases of cholera in the developed world as well. And it is entirely possible that in our everyday practice, we might be seeing many cases of acute watery diarrhea that may actually be due to Vibrio cholera, which we may not even recognize, and which may leave our facilities undiagnosed as cases of cholera. So we often hear of cholera in the setting of outbreaks and epidemics, but you can have sporadic cases of cholera which we may not even recognize because we don't do diagnostic testing on every case of an acute watery diarrhea. So having said this landscape, if we can go on to the next slide, this next slide talks about the etymology. So that's the next slide you have on the screen right now is the one that shows the pathogens involved in acute watery diarrhea of adults, right? And if we can go on to the next slide, which has the etymology and the history of cholera. So etymology, obviously, as you all know, is a study of how a particular word came to be used. And so cholera comes from the days way back 400 BC when Hippocrates was a big name in medicine. And it was thought that cholera was actually an outpouring of bile. Now, if you recall, back then, disease causation was considered to be imbalance between 4 humors. We have black bile, yellow bile, phlegm, and blood. These were the four humors. And in physiology, it was thought that these humors have to be in harmony with each other. So there are diseases in Hippocrates' writings that actually, in retrospect, we might consider to be descriptions of cholera. And the word came to be used because it was thought that it was an outpouring of bile. The Greek word for bile is chole, and the Greek word for to flow is rhea. So just like in menorrhea, rhinorrhea, cholera was thought to be the flow of bile. Another line of thinking is that choledra is also the word for a gutter, and a Greek word for gutter, and the way the effusion of diarrhea comes out, it actually is like the flow in a gutter. So that's another line of thinking as to how the word cholera came to be defined. Now, as I say, in the writings of Hippocrates, there are certain descriptions of cases that might actually be cholera, and these kinds of descriptions are also seen in Indian texts. And it was only in the 19th century that an English epidemiologist called John Snow worked out the connection between an infected water point and cholera. And I guess those were the days when they did not have piped water to every home in England and in their large cities. And they probably used to go and collect their water from water points. And there was one particular water point that was thought to be the point source of a cholera outbreak at that time. And when remedial actions were taken, the cholera outbreak dwindled away. And then in 1883, Robert Koch described the cholera vibrios. So under the microscope, it appears as a vibrating bacillus, which is why it got the generic name Vibrio. And of course, in that genus Vibrio, there are about 80 organisms. Vibrio cholera is just one of them. We've got Vibrio volnificus and others as well. So if we go to the next slide, we've got a pictorial record of the culprit here. You can see that unipolar flagellum. So if we go to the next slide, so cholera is caused by the organism called Vibrio cholera. I talked about the genus in which it falls. It's a comma-shaped, facultatively anaerobe gram-negative rod. I talked about the single polar flagellum. And it exists as a free-living organism in water. There is no animal reservoir, and that's an interesting observation. Evolution may have something to do with that. Now, there are very many strains of Vibrio cholera, but only those strains that produce the cholera toxin actually causes the disease cholera. So toxigenic V. cholera are the only strains that cause the clinical disease cholera. The strains of cholera are then further classified based on the O antigen, and there are more than 200 serotypes that are known. However, it is only serotypes O1 and serotypes O139 that have been associated with epidemics and outbreaks. Now, you can have non-O1, non-O139, which can still produce toxin, cholera toxin. Those will still cause cholera, but they will not cause epidemic cholera. They will not cause outbreak type of cholera. They'll just cause the occasional sporadic cases here and there. And then you have the non-O1, non-O139, which do not produce a cholera toxin. Those generally tend to be quite indolent. They don't cause much disease, but in immunosusceptible, immunocompromised hosts, it can cause sporadic gastroenteritis and even cause sepsis, much like what Vibrio vulnificus does in immunocompromised hosts. And in vitro, it grows better on higher pH media and in bile salts enriched media. And we'll come to this again when we talk about how to make a diagnosis of cholera. More pictures of the culprit here. This is a scanning electron micrograph, two of them. Here's another one. I really want to nail the case. I'm trying to bring all the pictures I can. Dr. Okunga will talk more about epidemiology. I'm glad we have him on this call. So I will do a rather amateurish job of describing the epidemiology of cholera. So as we all know, it is acquired by ingestion of contaminated food or water. Person-to-person transmission can also occur. So you can catch cholera by actually ingesting contaminated food and water, but you can also have fecal-to-oral transmission. Now, this is quite interesting because they've done some studies on organisms that have been isolated from the stool of patients as opposed to organisms that were isolated from the environment, including food and water sources. And they've done some nice modeling studies as well and animal inoculation studies as well. And it has been found that the organisms that come out in the diarrheal fluid of a patient with cholera is actually more infectious than the organism that is ingested from the environment. So that's an interesting little point there, which might explain why we have a tendency to outbreaks once it has set in because of this fecal-oral spread. But no doubt Dr. Okunga will tell us more about this. In areas of endemicity, there are peaks of infection that occur before and after the rainy season. And worldwide, it is estimated that we have 3 million cases of cholera occurring every year with about 100,000 deaths. There have been 7 recorded pandemics of cholera. We are actually going through the 7th pandemic. And then with the further classification, so I talked about O1 and O139. The previous pandemics were caused by the classical biotype of Serovar O1, but our present pandemic, which is ongoing, is caused by the LTOR biotype. In terms of risk factors, obviously exposure to contaminated food and water is a big risk factor. And then we will see when we come to discussing pathogenesis, we will see that gastric acid plays a big part in our defense against cholera. Therefore, a chlorhydria, gastrectomy, H. pylori infection, or the use of PPIs is an additional risk factor for cholera. And somehow it has been found that patients with blood group O have a higher susceptibility to cholera than patients with other blood groups. And then on the plus side, breastfed infants are found to be more resistant to cholera, and the use of hand hygiene also is a protective factor against cholera. And our next slide shows the reports of cholera made to the WHO from different parts of the world. And you can see that it's a predominantly tropical affliction, which goes with our understanding of how it inhabits in the natural environment. Our next slide will be a graphic representation of the pathogenesis of cholera. So the cholera organisms, the portal of entry will be the mouth and the gastrointestinal tract. And so it will be ingested. It has to pass through the gastric acid barrier to make it to the intestines, where it will cause symptoms. So once it colonizes the epithelium of the small intestine, it begins to produce and release cholera toxin, which then binds to the epithelial cell receptors, and the cholera toxin then goes on to become internalized, and you can see all the steps that then follow through to cause an increase in cyclic AMP, which then leads to an outpouring into the intestinal lumen of large quantities of sodium chloride and bicarbonate ions. It also causes kind of a paralysis of the CTFR, which is the intestinal epithelial cell receptor that is responsible for the reabsorption of chloride from the intestinal lumen. If you recall, it is the CTFR molecule that is mutated in patients with cystic fibrosis, and they cannot reabsorb chloride ions from the intestinal lumen, and then they end up having a very thick inspissated mucus formation. This is a process that happens in the intestines as well as in the lungs in cystic fibrosis patients. So in cholera, there is a temporary paralysis of this receptor, leading to large amounts of electrolyte-rich fluids being in the lumen of the small intestine, and then going on to cause the profuse watery diarrhea, which is the hallmark of cholera. So this then brings us to our next slide, which is the clinical features of cholera. Cholera has an incubation period of only 1 to 2 days. In fact, in some parts of the literature, it is mentioned that actually it can have an incubation period as little as 12 hours. And in the realm of infectious gastroenteritis, it is an axiom that pathogens that cause diarrhea through the agency of a toxin have a shorter incubation period than pathogens that actually cause epithelial cell destruction, because the latter have to reproduce and actually culture themselves on epithelial cells. So they will tend to have a longer incubation period. But with cholera, Vibrio cholera, the cholera toxin is either preformed or it forms very, very quickly. So you have a short incubation period. You have a spectrum of severity. You can actually have asymptomatic colonization of the intestines with Vibrio cholera. Some patients will not even exhibit symptoms. And we also know that there is very type-specific, short-lived, maybe not lifelong, but short-lived immunity that comes with upon recovery from an episode of cholera. So that might be contributing to why some patients might merely colonize their intestines without causing any symptoms. In some patients, you can have only mild diarrhea, and then in some patients, you'll have the full-blown severe watery diarrhea. Of course, you'll have a lot of stool. It'll be rice water in appearance. It will not be bloody. Some patients may have vomiting. Fever and tenesmus are quite rare in cholera. They tend to be the hallmarks of bloody diarrhea, of the invasive gastroenteritis. Often, as I said, the volume tends to be high. So a high volume diarrhea ought to raise suspicion for cholera. So there is a version of cholera called cholera sicca, in which what happens is that you've got this massive volume of fluid that is in the intestinal lumen, but somehow it doesn't make it to the anal introitus and it does not come out as diarrhea. And it just stagnates in the intestinal loops. This rapidly results in circulatory collapse and death. And I can see how this happens at the bedside, because if the patient doesn't have diarrhea but has abdominal distension, and we don't know what the abdominal distension is due to, but in effect, what is happening is that this patient is losing large volumes of electrolyte-rich fluids, which are not in the circulatory compartment. You can see this causing essentially a dry cholera, so to speak. Sicca is the word for dry. So the main morbid and mortal effects of cholera do come from the severe hypovolemia and the severe electrolyte derangements, which are a hallmark of this disease. And you often get renal failure and hypoglycemia. But once one has recovered from cholera, long-term sequelae are rare. And the usual case of diarrhea due to cholera takes about 4 to 5 days to resolve. If left untreated, mortality is stated to be up to 70%, but with treatment, it can be brought down to less than 1%. And our next slide shows a sample of the rice water diarrhea. I hope I do not inflict any gastronomic trauma on any of our audience. I hope you don't get put off for your dinner tonight, having seen this slide. I hope you will quickly forget it. Most of my talks have that effect. They are soon easily forgotten, so I don't think it'll be that traumatic. If we can go on to our next slide, which now we go into how to diagnose diarrhea. I would strongly suggest that when we are suspecting a case of diarrhea, we should just get about treating rather than delaying trying to get a diagnosis of cholera. Management should take priority over diagnostic testing. So the precise diagnostic testing comes from stool culture. We may require selective media. Selective media, what it does is it allows, or rather it prevents other common intestinal pathogens from growing and allow cholera to grow. We also have rapid antigen detection kits that can detect both the O1 and O139 serotypes. You can do a dark field microscopy, which demonstrates these organisms. Remember, they have a flagellum, so they would be dancing about. There would be this shooting star-like motion. In individual cases, we don't need stool culture that crucially, but we do need stool culture to define that we have an outbreak of cholera. And then the stool culture will also provide us with antibiotic susceptibilities, all the more important when we are dealing with an outbreak situation, so we know how to treat patients with cholera in that particular outbreak. Molecular techniques, a PCR test is available, but these are not available for routine clinical use. And then the other diagnostic tests which we would need are tests to assess for electrolyte derangements and the other sequelae of cholera. So our next slide we will start talking about how to manage cholera. so the biggest, management of cholera will be a three-legged stool, and the most important leg of that three-legged stool will be fluid and electrolyte resuscitation. That will be the most important part of treating for cholera. I will have 2 or 3 slides following this to tell us how we should assess volume loss and how we should treat that. So for cases of mild hypovolemia, we will want to treat that with oral rehydration solution. Ringer's lactate, or not, for when intravenous fluid repletion is required. Intravenous Ringer's lactate is to be preferred over normal saline. And what we want to do is, these patients have large volumes of fluid deficit, and we want to correct that within 3 to 4 hours of presentation. And in the previous slide, Dr. Guleid, if we can go back to the previous slide, that picture at the bottom is a cholera cot, which a lot of us are probably used to. Which the patient with cholera is placed on that cot, and it's got a cutout portion in the center where the patient then can just relieve himself or herself without having to get up. And if you have a measuring container at the bottom, it will also enable us to assess the fluid losses through diarrhea. So that is often used in outbreak settings, a cholera cot. So going on to the next slide, which was the slide that was on, the WHO has recommended this simple way of assessing for dehydration. This is a very simple Uakali way of assessing dehydration, which we can use in even the most basic of our health centers. We don't need fancy diagnostics. And we can divide up our dehydration into mild, moderate, and severe, which then guides our treatment approach. If we can go on to the next slide. The next slide is something similar. Right, okay, we've got our next slide on, only that this slide now tells you what is the level of volume loss in each case, between 5 and 10%, and the percentage losses of the volume in each of the mild, moderate, severe categories. And then if we can go on to the next slide, this one shows us what are the volumes of fluid we need to administer. In this one is specific to moderate dehydration. But the point that these 2 or 3 slides is making is that volume and electrolyte replacement is the most important part of the treatment of cholera. So if we can go on to our next slide, I can see that we are coming up to 45 minutes past the hour. So I do want to leave some time for Dr. Okunga to talk to us about epidemiology of the current outbreak we have in the country. But the next slide we have on the screen is the other two legs of this three-legged stool, which is antibiotics and nutrition and vitamins. So antibiotics have been shown to shorten the duration of diarrhea by 1 to 2 days. They've been shown to reduce volume of stool losses and also the duration of virus shedding. Now, in an outbreak situation, those with severe dehydration, those with comorbidities, pregnant women, and those with severe malnutrition are the ones we would target for antibiotic therapy. The choices are macrolides, fluoroquinolones, and tetracyclines. The slide that will come after this will go into more details in terms of our antibiotic choices. But then the third leg of our cholera management stool, indeed, an important leg in the management of other infectious diarrheas is optimal nutrition and vitamin supplementation. So it is recommended that oral feeding in cases of cholera should begin as soon as the patient can tolerate oral feeding. And zinc and vitamin A supplementation hastens the recovery of the intestinal epithelium. And we use these interventions in other infectious gastroenteritis as well. So if we can go on to our next slide, this one talks in more detail about the particular classes of antibiotics to be used. We have the tetracyclines, the macrolides, and the fluoroquinolones. And each has its advantages and disadvantages. You can see that probably azithromycin has an edge over all the others in terms of cost, efficacy, and the simplicity of treatment. Obviously, anything that can be used as a single dose treatment for the management of cholera will have an edge over treatments that require multiple doses. And cost always is an important factor, but also the tendency for the Vibrio cholera to become resistant to the particular antibiotics we are going to employ is an important consideration. And so in an outbreak situation, we will probably want to know what antibiotics the circulating strain is susceptible to be in order to guide our antibiotic choices in the management of the outbreak. So let us see how people develop immunity to cholera. So to any pathogen, not just Vibrio cholera, there are two broad types of immunity that the body employs in combating the pathogen. So there is innate immunity and there is adaptive immunity. And a few minutes ago, I did mention that there is some short-lived immunity, maybe lasting up to 3 to 5 years. It's a very type-specific immunity upon recovery from an episode of cholera. So this then reflects the innate and the adaptive immunity that our body develops to cholera. So the innate immunity is the one that kicks in immediately upon entry of the organism into the body. It's a very broad inflammatory response. It's marked by an influx of inflammatory cells, macrophages, neutrophils, lymphocytes, and other effector cells. And then the adaptive immunity, the immunity specific to Vibrio cholera, then kicks in. And we start developing antibodies to the O antigen. And these antibodies then go on in future if the patient were to be infected with cholera again. The antibodies to the O antigen would inhibit intestinal colonization and motility. An antibody is formed against the cholera toxin itself. So you then, those antibodies would inhibit the binding of the cholera toxin to the intestinal epithelial cell receptor. And you also have serum vibriocidal antibodies to Vibrio cholera. And to the extent that these vibriocidal antibodies would make it into the intestinal lumen, they would provide additional killing power. So once we understand how the endogenous immune response to cholera develops, we can actually create an artificial immune response through vaccines. So if we can go to our next slide, that one gives an overview of the vaccines that are currently available. All these vaccines are oral vaccines. Two of them are killed whole cell vaccines. One is a live attenuated vaccine. Of the killed whole cell vaccines, the one called Dukoral is monovalent. It is active only against the O1 serotype of Vibrio cholera, whereas Shancol and Uvicol are bivalent. They are active against both O1 and O139. But having said that, and again, Dr. Okunga might touch on this, the O1 serotype is by far the bigger problem we have to worry about. O139 is not a very big player currently. It did rear its ugly head a few decades ago, but it doesn't seem to have persisted in nature, and at least in the strains that cause human disease. So they are primarily vaccines are primarily recommended as part of a cholera prevention program in areas at high risk of outbreaks. So this would be before an outbreak has occurred. But it hasn't taken off very well in many parts of the world, this pre-outbreak vaccination program. More common, the use is after an outbreak has already started, so that you reduce the scope of spread of the epidemic. But if we are going to talk about prevention, then improvement in water supply and sanitation, the so-called WASH, water, sanitation and hygiene, is by far the more important element of cholera control. If we look at countries that have managed to bring cholera under control, they've done it through improvements in water supply and sanitation, not through mass vaccination. So this brings me up to my penultimate slide, the summary. So to summarize, cholera causes an acute watery diarrhea caused by the organism Vibrio cholera. It's transmitted in infected food and water. It has a tendency to cause outbreaks and epidemics. And profuse watery diarrhea, rice water stools, is its hallmark, and it causes severe volume and electrolytes depletion. And in the management of cholera, the aggressive correction of hypovolemia and electrolyte abnormalities is the most important part. Antibiotics and optimal nutrition also have their place, and in terms of prevention, water, sanitation, and hygiene are the most important modes of prevention, but vaccines also have their place. And I will urge your indulgence to look at this last slide, which is from an aphorism of Hippocrates. Dr. Guleid, here. Yeah, it's from the aphorisms of Hippocrates. And I did mention that Hippocrates did describe a disease that we could today recognize as cholera. And it is instructive. He goes on to talk about how in disorders of the bowels and vomitings occurring spontaneously, if the matters purged be such as ought to be purged, they do good and are well born, but if not, the contrary. And so artificial evacuations, if they consist of such materials as should be evacuated, do good and are well born, but if not, the contrary. One then has to look to the country, the season, the age, and the disease in which they are proper or not. how many, 2,700 years, no, 2,600 years ago, even before we knew how cholera was caused, before we knew how infectious diseases were caused, Hippocrates did recognize the epidemiological aspects of an infectious gastroenteritis. Look to the country, the season, the age, and the disease in which an infectious gastroenteritis occurs to find its proper cause and thence its proper management. Because here he tells us that there are some diseases in which purging is all right, and there are some diseases in which it is a complete no-no, which is what we recognize today in the management of infectious gastroenteritis. I fear I've taken a little bit more time than I wanted to, but I hope we will lend Dr. Okunga our ears for him to give us his part of the talk. But once again, thank you for inviting me to give this talk, and I will stick around for questions and answers and comments.
Kindly, Dr. Ari, please don't go away. There are lots of questions already, and I can't wait to hear what Dr. Emmanuel Okunga has to say. Dr. Emmanuel Okunga is the acting divisional head in the disease surveillance and response in the Ministry of Health. He's here to bring us, we've talked about cholera, and Dr. Ari, you have done an amazing job in making us understand cholera better. So Nelson is going to quickly share Dr. Okunga's screen so that he can be able to share the updates of what is going on in the country. Where are we having cholera? Are we having deaths? And which counties are the most affected? So Dr. Okunga, how are you?
Thank you so much, Dr. Guleid. And,
yes.
And good afternoon, colleagues.
Good afternoon. Good afternoon, Dr. Ari. So quickly, Nelson is going to share the screen. He's just probably just setting it up for you. But in the meantime, you can start with a few words.
Thank you so much, Dr. Guleid, again. I think Dr. Hafiz has made my presentation so much easier. And just to start with where he ended on the aphorisms of Hippocrates, I think for us contextualizing cholera in our country, we first reported cholera cases in this country in 1971. And since then, we've had repeated outbreaks, cyclical outbreaks almost annually, but most aggravated when we have extreme weather conditions like El Nino and La Nina. And a lot of outbreaks have been related to water bodies and then drought situations. However, we are seeing that a lot of the outbreaks today are being driven by urban slums, also being driven by congestion in the refugee camps, poor, overwhelmed sewer systems, and outside catering. So that is a general overview of what we are seeing in the country, and we've seen more and more outbreaks as we've progressed over the years, but they're also becoming larger. So cholera remains an area of major concern to the country. So from the ministry perspective, I'll be giving you a situation update on the current outbreak, which began in October 2022.
Sorry, Dr. Dr. Okunga, sorry for interrupting. I just wanted to clarify, can you be able to see in the screen? Because I can see it on my gadget, but a mobile, but not the desktop. So are you able to see
I'm seeing it? I'm
Okay.
seeing it.
Okay. Great. Perfect.
Yeah. So this situation update is at 24th January. So next slide, please. So from October 2022 to date, we've had more than 4,000 cases, 150 of which have been confirmed by culture and 11,082 by RDT. We've had a total of 82 deaths, giving us a case fatality rate of 1.9, which is above the WHO recommended 1%. Now, so far we've had 14 counties or 30% of the country affected by the outbreak, although we have controlled the outbreak in at least 3 counties. Next slide, please. So that's just a list of the counties that have been affected. And as you can see, the bigger caseloads are in Garissa, Tana River, Nairobi. The initial cases, of course, arose from Kiambu, but we now have cases down. Machakos, we had cases related to prisons and School of the Blind. Wajir, these are cases that have spread from Garissa, from the refugee camps there. Meru, Nyeri, Muranga, these were related to the Kiambu cases. Homa Bay has come on board lately, and this we think is mainly due to Christmas travel. Kitui, the cases there are related to the cases in Tana River and are within a sect of the Kavonokia who do not like going to hospital. Kajiado, Uasin Gishu, and Nakuru were all related to the cases in Kiambu. Next slide, please. So this is the national cholera epidemic curve. As you can see, we had a peak of an early peak around November. This original one, these were cases from institutions in Machakos. This was a point source outbreak, and we had large numbers of infections in a prison there and an institution. However, generally, at national level, our cases peaked around December, another peak around January, but generally coming down now. In red, you can see that we've lost quite a number of people over the years, and it speaks over the months, and it speaks to the kind of case management happening in our facilities in the counties. Testing, I know Dr. Hafiz had already indicated, testing in an outbreak is mainly for epidemiological monitoring, although a lot of our clinicians have insisted or persisted to test each and everybody out there. And that is not our national guidelines, but I think testing brings peace to many people, I bet. Next slide. So we've picked out a few epicals for the different counties just to show you the progression of the outbreaks in the various counties. And you can see Nairobi, we are now having sporadic cases. The bigger burden was around November. We think that we are getting the situation in Nairobi under control. However, we need to get this fixed before the long rains. Otherwise, we'll have an upsurge of cases. The cases in Nairobi are largely driven by broken sewers in the urban slums, and we've also had food vending, which has contributed to the situation in Nairobi. And of course, as you'll see, a number of the deaths in Nairobi have been associated with young men. And we think this is related to the illegal alcohol brews they are taking in the slums. Next. So for Garissa, again, the bulk of these cases are in the refugee camps. As you may know, the drought has displaced a lot of people from Somalia. And as of early last week, we've had an additional almost 80,000 refugees coming into the country on top of the routine refugees in the Dadaab camp. So we have an influx of people in Hagadera. So this has been quite a challenge, although we are stabilizing the situation in Garissa. By usual delivery of the WASH interventions there. Next slide. So for Kiambu, we are stabilizing the situation in Kiambu. The outbreak there was driven by weddings, really, and we think it was mainly use of contaminated foods brought in by outside caterers. However, a lot of work has been done by Kiambu, and we think that will bring the outbreak under control soon. Next. So this Tana River, as you can see, though the cases are coming down, but you can see that we've had significant deaths there. And this is happening in Bura sub-county, Madogo area. And this speaks to the case management challenges again in the counties. The cases there are still ongoing. We are sending further teams to support the county there to manage that situation. Next. Wajir. These Wajir cases are related to the cases in Garissa from the Hagadera refugee camp, but they've spread to Wajir South and Wajir East. And as you can see, we are having quite some deaths there also. As you know, our WASH situation in Northeastern is quite a challenge. We still have a lot of open defecation and the congestion in the camps. The drought situation has not made things any better. So this is a complex emergency we are dealing with in the region. Next. So when we look at the age distribution of the cholera cases, you can see, I know Dr. Hafiz referred to the aspect of breastfeeding and its protective effect. And in our guidelines, cholera guidelines, we actually focused on the above 2 years during outbreaks. However, you can see we have a significant number of children below 2 years that are reporting with confirmed cholera cases. So maybe as we revise and update our cholera guidelines, we need to invite some of you to come and also help us to get a clear understanding of what is happening in these age groups. However, largely because we have a large population below 15 that is infected, this is an indicator of household level transmission. And a lot of it is related to hygiene and open defecation issues in most of the households. Next. So again, when we look at it in terms of sex, it's almost no difference. And across the ages, you can see the distribution is fairly even. Next. So that's a map of the cases, and you can see from the biggest case load is from Garissa, but This is also now affecting the neighboring counties of Tana River and Wajir. And then Nairobi in there also has a number of cases which have spread to the neighboring counties. Next. So we've also analyzed the deaths. Maybe next slide. So far, as I had said, we've had 82 cases, and you can see most of them have occurred in Nairobi, 29, in Tana River, 17, and Garissa, 11. Next slide. And this is an epidemic curve of the cholera deaths. To date, you can see we are still having more deaths. This should not be the situation. At least if people were learning, the deaths should have been coming down, but it appears like we're having more deaths, probably due to the larger caseload, but largely because of poor case management in our health facilities. Next. So you can see from the death, when we do age analysis, most of the deaths are between 36 to 45. So we can actually say young adults and then children 1 to 2 years. And when we look at the sex analysis, 78% of the deaths are males. Next. This is a distribution of the cases by county and sub-county and the place of death. So in red, those are community deaths. In blue, those are health facility deaths. And as you can see, most of the deaths are occurring in health facilities. You can see Bura in Tana River is not looking very good. And Mathare, Mbakasi East, Dadaab and Thika. Next slide. So what are the interventions the government has put in place? We have an incident management committee. We've also developed a national cholera response plan. We continue to meet with the affected counties regularly. And we are monitoring the county response activities across all the thematic areas of response. We've trained county level officers in 8 of the affected counties. However, we are not sure that they've been able to cascade this training to their sub-counties and the health facilities. And this is one of the areas we are emphasizing on getting out there. Next. So again, we've been able to send supplies to most of these counties. We've sent cholera kits to the counties. We've also sent emergency interagency humanitarian kits to these counties. And more supplies are still being sent there. But we think that more technical assistance needs to go to the counties to help them even use those commodities they are receiving. And then lastly, we are planning to conduct an oral cholera vaccine campaign beginning 4th of February in the hotspot counties of Nairobi, Mathare and Embakasi East. Garissa is Garissa Town, Dadaab, Fafi and Lagdera. Wajir East and Wajir South, and Tana River in Bura sub-county. These counties have been selected based on a hotspot mapping we've done for the country, which is based on both historical epidemiological data and the worst situations in the various sub-counties. Next, I think that was the last slide. Thank you very much for paying attention.
Asante sana. Asante sana, Daktari. Yeah, asante sana, Daktari. That it's really good news when we hear that we're moving towards even not just giving them supplies, but also giving the vaccine based on the data in terms of taking it where exactly is most affected. And we're going to quickly go into the Q&A sessions. And please, for Dr. Okunga as well, please don't hesitate, ask your questions on the Q&A platform. So there are several questions that have come, and I'll try and batch them so that we can have some uniformity in terms of asking. So symptomatically speaking, Dr. Hafiz, you showed us the rice, which hopefully it didn't affect people's lunch, leave alone dinner. uh, so the question was, is it foul smelling? Does it have a smell? What other characteristics would we be looking out for?
So I would say that maybe at the very beginning, it may have a fishy odor. But what may happen as the diarrhea progresses is that fishy odor will disappear because you've got a very profuse diarrhea, and that fluid that is coming out at the anal end has probably not stayed in the intestinal tract for very long. It's just coming out mass production. So I think the initial diarrheal movements may have a fishy smell to them, but I don't think the subsequent ones will have any odor to them.
Okay. And there was a symptom you mentioned that I found very interesting, or rather a clinical presentation, the Zika. You mentioned also it's also rare. Does it end up being a surgical emergency? And how would somebody know that that's cholera?
Right. I think it's that's the challenge of cholera Zika. Fortunately, it's very rare. I can imagine some of these patients have probably been submitted to surgery, though they would probably not have intestinal obstruction, classically speaking. And I think what happens is that in this particular variety, death ensues very, very quickly because you've got circulatory collapse, which you haven't recognized what it is due to. And you might therefore try to take your time. You might even recognize it as sepsis. And, while you're trying to rehydrate, you might lose a patient. But it is very difficult to recognize, and it has a very high mortality rate because of the profound hypovolemia.
Thank you. Then on pandemics, in your presentation, you mentioned like we've had several pandemics, 7 if I'm not wrong, and the most common type is 0.01 if I'm not wrong as well. And
That's
maybe,
correct.
yeah. So Dr. Emmanuel, there's many questions regarding to which one do we have, and also in that regard, which vaccine do we have? Because Dr. Hafiz has also clarified to us that some vaccines only act on one as opposed to both. So which vaccines do we have currently in stock? And also which one is the most common one currently affecting Kenya? Dr. Emmanuel?
Thank you very much, Dr. Guleid. So for now, I think the predominant serotype we're having is O1 or GAWA. And this has been the pattern for most of the time. We usually have a bit of INABA sometimes, but for this particular outbreak, what we've seen is largely OGAWA. The vaccines we are to deploy, we'll deploy 2 types of vaccines, Shankol and Uvicol. And this is largely guided by the fact that we have a global shortage of vaccines. Many countries have outbreaks and the global stockpile is limited. So we'll only have about 2.2 million doses for Kenya. That's why we've prioritized as I had indicated. So we'll be deploying Shankol to Garissa and then UV-Col to the other counties. Over to you, Dr. Guleid.
Okay, thank you, Dr. Thank you for that quite very informative information. Then on with regards to treatment, Emily Babu is asking a rather very engaging audience. Is during her time, they literally used to have to take the pod of doxycycline and administer it to children, you know, probably in a water, after shaking it with water, I'm assuming, and give them with ORS and zinc. And she just wants to know, Dr. Hafiz, is that a correct approach? And is it something that actually works? And is on that regard, you can also answer. You mentioned doxycycline, tetracycline, macrolides to be and fluoroquinolones. Are they all safe in all age groups, or do we have to look into ages as a factor in choice of antibiotics? And if it's necessary in all cases of cholera? Dr. Hafiz, I'm sorry, I hope you've digested all my questions.
Yes, I might have to ask you to remind me of, actually, it's not just reminding, I actually didn't get the first part of the question, which was the doxycycline was being administered to kids in a particular fashion?
Yeah, like so it comes in the form of cups. And the way I'm understanding her question is they would remove the pod of the cups, mix it with water to give the children so that they can be able to get better.
All right. Okay. So not being a pharmacist or pharmacologist, with that caveat, I'm going to say that that seems to be an okay way of administering the doxycycline to kids. But once again, I think I would emphasize that the most important pillar of treatment is going to be the correction of volume and electrolyte derangements. We don't always have to give antibacterials. And in fact, I think I just peeped into the chat box, and there was one question about whether or not antibacterials are needed, given that it's a toxin-producing illness. I can touch on that later. But again, in terms of management, I think the correction of hypovolemia and electrolyte abnormalities is probably the most important part of management. The reason antibacterials get proposed for the management of cholera is because, number one, this occurs as outbreaks, and number two, there is some evidence that you reduce bacterial shedding in the stool, you reduce the duration of diarrhea, and you reduce infectiousness with antibacterials. But if they are not available, the correction of hypovolemia and electrolyte abnormalities and the correction of malnutrition are by far the more important components of management.
Maybe if you can
Dr.
allow Dr. Guleid, can add something small.
Yes, go ahead, Dr. Okunga.
Yeah, so now for our cholera guidelines, basically we are encouraging for children erythromycin, and then doxycycline, we are limiting it to adults, non-pregnant adults. However, again, from our recent studies on AST studies, we've had a lot of multi-drug resistant cholera in the country. So again, ASTs should guide our antibiotic choices. And as Dr. Hafiz has said, antibiotics are not the mainstay for cholera management, but where we have to reduce stool volume and viral shedding. And also, one of the things we also use antibiotics for is prophylaxis of household contacts. So we need to have some regular ASTs done. Back to you, Dr. Guleid.
Yeah, so thank you, Daktari. And yeah, earlier on, you had showed us the different distributions of cholera in the county levels, and Dr. Hafiz had mentioned that WASH, in terms of prevention, WASH is actually the mainstay, more than even vaccine. So what I'm sure the ministry is doing things behind the scenes, and maybe you can shed light, because also some of the members, the audience, are asking what have we done in the WASH part arm of prevention.
Thank you, Dr. Guleid. Again, we align with Dr. Hafiz's position that WASH is actually the hallmark for cholera control. And as a country, we have always emphasized WASH. That's why even the use of vaccine has been delayed in this country, because the ministry feared the consequences of introducing vaccine and then people run to vaccine and forget about WASH. So one of the key things we've done in terms of WASH is, first, our national cholera elimination plan, which we developed last year to follow up on the previous national multi-sectoral cholera control plan, brings together different line ministries, including Ministry of Water, Environment, and Internal Security, Provincial Administration, all that. Because we realize that the health sector actually deals with the effects of cholera. But the things that need to be done to sort out cholera, like proper sanitation, safe water, actually a mandate of different ministries. So in the current elimination plan, we've mapped out hotspots of poor sanitation, hotspots of low water coverage, and this hotspot mapping is now guiding the interventions being undertaken by the Ministry of Water. So we are having boreholes being put up in those hotspot counties, and also increased water reticulation in some of those counties. That we believe is the way to go forward. In Nairobi and other urban areas, you know the challenges we have in slums, but you also remember that last year we had a lot, the other year, we had a lot of borehole erection in many of our slum areas. However, we all realize that the sanitation challenge is huge and requires a lot of investment. So this is work in progress. Over to you, Dr. Guleid.
Thank you. Thank you very much. So the other questions are on treatment, and the questions are quite dynamic. We've covered antibiotics, so maybe we go a little bit on fluids. Dr. Hafiz, if you're
Yes.
to pick between Ringer's lactate or normal saline, I know might be a trivial question, but it's a commonly asked question in the healthcare world. Which one do you pick? Do you give Ringer's lactate? Which one is preferred?
I would say Ringer's lactate has a slight edge over normal saline. Slight edge. But I mean, if a facility doesn't have Ringer's lactate, and all it has is normal saline, that's what I wouldn't shy away from normal saline. Ringer's lactate has a few other components, which and even in sepsis and other types of shock, Ringer's lactate appears to have an edge over normal saline, less tendency to cause hyperchloremia, and in some of the sepsis trials, Ringer's lactate has caused less renal insufficiency as compared to normal saline. But having said that, it is more important to correct the hypovolemia than to quibble about normal saline versus Ringer's lactate.
Yeah, thank you. Thank you very much. So it's not really something you should argue about. Just put the one which is closest to you and save that person's life. In terms of, last week we had this very engaging discussion on medical, how to certify death. So in the form of cholera, what would be like the most under cause of death? Would you put it as cholera, or would you say it's because of AKI or hypovolemic shock? What's actually, Dr. Emmanuel, probably you can shed light on what is actually making Kenyans die right now, and Dr. Hafiz can expound more on probably globally what's happening.
All right, I may not be the right person to do this. Maybe the pathologists would be the correct people to do this. But largely, I think what we would say is cardiovascular arrest due to volume depletion. But I think you clinicians would be the right people to better describe this. Although I also think we may be splitting a bit of hairs. Cholera, you've lost fluid, you've lost electrolytes, then you die. Maybe Dr. Hafiz, you can help out.
Yeah, sure.
Yeah.
I'll take a stab at it. I would say if I was to write a death certificate, if the patient had a very specific organ dysfunction, like acute kidney injury, and it was demonstrated ante-mortem, then I would put that down, acute kidney injury, secondary to severe hypovolemia, secondary to cholera, or secondary to Vibrio cholera. If there wasn't, then the death certificate might just look like severe hypovolemia and due to cholera.
Okay, so with that, we have a few more minutes, and I usually like reserving the end. I'm sorry we cannot be able to answer all the questions because there's so much. Maybe we can just have like quick summaries from both of you. Dr. Emmanuel, you can start. Dr. Emmanuel?
Yeah, thank you, Dr. Guleid. So I think the take-home message for us is cholera still is a major cause of death in this country during epidemics. It's an old world disease, so to say, but we'll confront more and more cholera because of the kind of risk factors that exist in our environment. However, with a bit of investment in WASH and targeted interventions in the hotspot areas, we can actually eliminate cholera from this country. So as medical workers, we need to pull together and guide our respective counties on how cholera control, cholera elimination can be achieved. But also in the facilities particularly, we need to guide the younger colleagues who've never seen cholera cases to emphasize the need for rapid volume replacement to be able to prevent deaths. A key area that we are missing out is ORS, particularly from the community before we refer. So people come when they're already having acute kidney injury, and so they are dying very soon after admission. So a few of those issues, we need to mentor our colleagues out in the facilities so that we avoid deaths. So over to you, and have a good afternoon.
Good afternoon, Dr. Dr. Hafiz?
All right, so let me begin by first saying asante sana for asking me to come and talk about this very important topic. I think my parting comments are that at the end of the day, it is still a syndromic approach, because patients will not come to us telling us that they are suffering from cholera. They'll come to us suffering from an acute watery diarrhea. And the key is in recognizing it and treating it. And again, the message to be underlined is that the more important part of treatment is the management of hypovolemia and electrolyte disturbances. And then if we recognize this as part of a cholera outbreak, then the appropriate antibiotics can be administered. As you know, this is probably the only, if not the only, one of the very few acute watery diarrheas where treatment with an antibacterial is indicated. Otherwise, the value of knowing that this is cholera is A, for the epidemiological purposes, and B, because in very few other acute watery diarrheas would we be recommending an antibacterial. And we talked, Dr. Okunga talked very nicely about what we as a country need to do to reduce the incidence of cholera outbreaks here. Thanks.
Thank you, Daktari. And one of the questions that I actually meant to ask and forgot was in regards to Mombasa. How comes Mombasa missed, being as part of the statistics in the cholera outbreak? But those are questions maybe we can look into some other time. But as usual, thank you everybody for listening in. If you would like to hear this session again, you would find it in our YouTube channel, and kindly subscribe. And also you can check for more content on our Twitter handle. Tomorrow we'll be having a session on mental health in cancer. And the day after, we're going to have Annette. We missed her last week on the Kenya health laws. We're going to discuss more about Kenya health laws. So go online, read about the health laws, and ask us questions so that we can get the drafter, one of the few drafters we have, to address some of them. So thank you very much, Dr. Hafiz and Dr. Emmanuel Okunga, for your time. We really appreciate it from everybody in KNH. And thank you everybody for listening in. Goodbye. And it's
Asante.
Yeah, asante sana. So
Asante sana. Goodbye.
Bye-bye. Asante
Bye-bye.
sana, Daktari. Bye-bye, people.
Asante.